Embryology of the respiratory system. Development of the lower respiratory tract begins to form during the 4th week of development. It begins as a median outgrowth laryngotracheal groove from the ventral wall of the primitive pharynx foregut. The groove invaginates and forms the laryngotracheal respiratory diverticulum. A longitudinal tracheoesophageal septum esophagobrachial develops and divides the diverticulum into a dorsal portion, which is made up of primordium of oropharynx and esophagus, and a ventral portion which is made up of primordium of larynx, trachea, bronchi and lungs. The proximal part of the respiratory diverticulum remains tubular and forms the larynx and trachea. The distal end of the diverticulum dilates to form lung bud, which divides to give rise to 2 lung buds, primary bronchial buds. The endoderm lining the laryngotracheal diverticulum gives rise to the epithelium and glands of the respiratory tract. The surrounding splanchnic mesoderm gives rise to the connective tissue, cartilage and smooth muscles of the respiratory tract. The opening of the laryngotracheal diverticulum into the primitive foregut becomes the laryngeal orifice. The epithelium and glands of the respiratory system are derived from the endoderm. Laryngeal muscles and the cartilages of the larynx except epiglottis develop from the mesoderm of 4th and 6th pairs of pharyngeal arches. By the end of the 5th week, the bronchial buds on the right side develops into 3 buds while that on the left develop into 2 buds. The 2 primary bronchial buds grow laterally into the pericardioperitoneal canals. Bronchial buds divide and radivide to give rise to the bronchial tree. The right main bronchus is slightly larger, wider than the left one and is oriented more vertically. The main bronchi subdivide into secondary bronchi, then into tertiary segmental bronchi, which give rise to further branches. Maturation of the lungs is characterized by 4 periods. Firstly, the pseudoglandular period. Secondly, the canalicular period. Thirdly, terminal sac period, and lastly, the alveolar period. In the alveolar stage, for proper gas exchange, these 3 things must occur. Firstly, surfactant production. Secondly, transformation of the lungs from secretory to gas exchange phase. Thirdly, establishment of pulmonary and systemic circulation. By 24 weeks, the terminal sacs are lined by squamous type 1 pneumocytes and rounded secretory type 2 pneumocytes that secrete a mixture of phospholipids called surfactant. Surfactant production begins by 20 weeks and increases during the terminal stages of pregnancy. Fetuses born prematurely at 24 to 26 weeks may suffer from respiratory distress due to surfactant deficiency but may survive if given intensive care. 95% of alveoli develop postnatally. About 50 million alveoli, 1/6 of the adult number, are present in the lungs of a full-term newborn infant. From 3 to 8 years or so, the number of alveoli continues to increase, forming additional primordial alveoli. Before the 10th year, the adult complement of 300 million alveoli is present. With air entering the alveoli during the first breath, the surfactant coat prevents development of an air-water interface with high surface tension. Without the surfactant, the alveoli will collapse during expiration atelectasis. The lungs at birth are half filled with fluid derived from the amniotic fluid and from the lungs and tracheal glands. This fluid in the lungs is cleared at birth by 1. Pressure on the fetal thorax during delivery. 2. Absorption into the pulmonary capillaries and lymphatics. *** Clinical correlates includes *** 1. Esophageal atresia, birth defect where the esophagus ends in a blind pouch and does not connect to the stomach. Babies cannot swallow food into the stomach, leading to choking, coughing, and feeding difficulties, often associated with tracheoesophageal fistula. 2. Tracheoesophageal fistula TEF, an abnormal connection between the trachea and esophagus. It allows swallowed food or liquid to enter the lungs, causing aspiration, choking, and recurrent pneumonia. 3. Tracheal stenosis and atresia. Tracheal stenosis is the narrowing of the trachea, making breathing difficult. Tracheal atresia is the complete absence or closure of the trachea, a rare and usually fatal congenital anomaly. 4. Congenital lung cysts, abnormal lung tissue forming fluid or air-filled cysts during fetal development. Persistent cysts can cause infection. 5. Agenesis of lungs, a rare congenital condition where one or both lungs fail to develop. In unilateral agenesis, one lung is absent but survival is possible. Bilateral agenesis is incompatible with life. 6. Lung hypoplasia is incomplete development of the lungs, with fewer alveoli and reduced lung tissue. It leads to severe breathing problems in newborns. 7. accessory lung cysts when extra lung tissue or lobes formed due to anatomical variations in fissures and lobes. It is usually asymptomatic but can complicate surgery or predispose to infections. 8. Respiratory distress syndrome or DS. This is a serious lung condition in newborns, especially premature babies, caused by lack of surfactant, leading to collapsed alveoli. Symptoms include severe shortness of breath, rapid breathing, and low oxygen levels. In summary, the respiratory system, which begins to develop in the 4th week of intrauterine life, is an outgrowth of the ventral wall of the foregut. The epithelial lining of the larynx, trachea, bronchi, and lungs originate from the endoderm. The cartilaginous, muscular, and connective tissue components arise from the mesoderm. Faulty partitioning of the foregut by the tracheoesophageal septum causes esophageal atresia and tracheoesophageal fistula.
If you found this helpful, make sure to like, share, and subscribe, and I'll see you in the next video.